Okay, good morning, and thank you very much for inviting me to this very important conference. I'm used to speaking at conferences, but rarely, I'm normally talking to professionals in the field, and my understanding is that the audience is primarily made up of people, I don't particularly like the word service users, but people with hypermobility related issues, and I'm excited to be talking with you today. So, just as by means of an introduction, who am I, why am I standing in front of you today talking? Well, as mentioned, I'm a consultant psychiatrist, so I'm a medical doctor trained in psychiatry, and I'm based in London. And I primarily work privately. I have a clinic called the Integrated Practice in Harley Street, and I work also one day a week in the NHS in a specialist adult ADHD service. There's not very many of them, but I work in one in Barnet Hospital. And my specific role there actually is to run what we call a life skills group for adults with ADHD. So thinking not about medication, because that's already done quite comprehensively, but it's thinking about everything else. Living successfully with ADHD. And I'm very passionate about the topic. When I was trained as a medical student and even as a psychiatrist, I was on the understanding that ADHD was this condition of childhood and adolescence, and miraculously it just sort of dissolved away at the age of 18. But the reality is quite different. And when I started to have a radar for ADHD in adults, I realized that it actually accounts for a huge amount of unrecognized pathology, psychological, physical, social, and it's often missed. So I got involved, and I sit on the main professional organization for ADHD in the UK called UCAN. I sit on their executive board, and I'm the training program director. And it's interesting because I can see quite a lot of parallels between the work that we're trying to do in ADHD, the education, the recognition, the issues around stigma. I can see many parallels with the field of hypermobility, EDS, etc. So how did I come to develop this interest in hypermobility? Well, I see a lot of patients with ADHD, and I try and do as thorough an assessment as possible. And what I started realizing was that a disproportionate number of my patients with ADHD were reporting, at the time, joint hypermobility. And I thought it was really quite significant numbers. And I thought this was interesting, and I decided to do a little bit of background reading and education. And I found very little, actually, about ADHD and hypermobility. But what I started doing was start screening my patients informally, my anxiety patients, because I don't just do ADHD, but also my patients with ADHD. And I started getting about a third of my patients have issues with hypermobility, and many of them with hypermobility syndrome. And this is not something that's in the ADHD literature at all. So I'm actually starting to suspect, and I'm sort of throwing this out here as a sort of introduction, but I'm starting to question whether a cohort, a percentage or a proportion of the patients with ADHD actually have it secondary to hypermobility syndrome, and how that could possibly be the case. And it's quite a radical and controversial thing to say, I'm aware of that. And certainly when I discuss it with my ADHD colleagues, they sort of look at me quite strangely, like I've got, but obviously it's a genetic problem with neurotransmitters and brain chemicals, and I'm wondering whether actually that's entirely accurate. So, how do these two problems link together? Well, I think we all know, and the reason why we're here is that psychological dysfunction is really very common in hypermobility spectrum disorders. And there's been various associations. We saw a couple of the studies that have been done, and anxiety issues come very high up. Some other neurodevelopmental issues, particularly dyspraxia, are often mentioned in the literature. But there's very little mention, until recently actually, about ADHD. There is quite a lot of references to people with having attentional issues, brain fog, etc. Anyway, as I dug around, and this was 5 years ago, I found one study from Turkey, the study I've listed here, Tanner et al. From 2011. And this study took a group of 54 children with diagnosed ADHD, and they assessed those children for joint hypermobility syndrome. And they found 31.5% of that group met the criteria for joint hypermobility syndrome, which is similar to the findings that I'm getting in my clinic. There's been a paper which was talked about by Jessica Eccles, which is an interesting and useful read. And last year there was a paper, I think it's in a journal, an ADHD journal. Last year a paper came out sort of putting a bit more understanding around the potential link. And it's interesting because my understanding that I've picked up over the last few years is mirrored with the model that they present. Okay. So how can we potentially explain the connection between hypermobility syndrome and ADHD? Well, one way of explaining it is through what's called dysautonomia. So I'm going to talk a bit more about what that is for those of you who aren't familiar with it. And in particular, dysautonomia linked with something called orthostatic intolerance. Another explanation, you have to think of our systems as energy systems, and we have a finite amount of energy. We need energy for everything we do, for interacting with the world, for focusing our attention down. And there are various things that absorb or zap energy. And one of them is having to be more attentive to where your body is in space, to having to think rather than flow when it comes to movement. Okay, so you're using up energy to compensate for proprioceptive or coordination difficulties. The same logic applies to pain. When we're in pain, chronic pain, it absorbs our energy and diverts it away from other areas. There is something that some of you may be familiar with as an eye-related problem linked to EDS called convergence insufficiency. And that is something to do with the eyes essentially tending to splay out when reading. Again, it's to do with, I assume, to do with collagen and laxity, and the eyes splay out, and it takes energy to keep them in. So you can see the theme running through here, that maybe the energy that we would be using for attention and concentration is being otherwise used elsewhere. And we have to consider also the potential that these two conditions, hypermobility spectrum disorders more generally, and ADHD, might sit close to each other in the DNA. Okay, so if someone is inheriting ADHD, maybe they're inheriting that segment of the chromosome that also has hypermobility problems. So are there genetic factors that can explain the link? And the truth is that we don't really know yet. Anyway, this was an image that was in that paper that came out last year, the 2018 paper, which illustrates what I've just explained. It talks about the issues with proprioception, the dysautonomia, the effects of pain, and the links with developmental coordination disorder, which is another way of saying dyspraxia. Okay? And this line down the middle is pleiotropy, is sort of shared genetic causes. So what I'm going to just draw our attention to is what I think is probably the most likely explanation, which is to do with the autonomic nervous system. And I'm going to just give a little bit of background of what we mean by dysautonomia. So one of the nervous system that we have is the autonomic nervous system. There's the central nervous system and the autonomic nervous system. And this is a balance between two opposing forces. In fact, everything in the body is a balance between two opposing forces. The idea of homeostasis is one thing pushing against the other and creating a balance. And not all systems are balanced. And the two systems that are involved in the autonomic nervous system are the sympathetic nervous system, which many of you will understand as the fight or flight system. It's behind the stress response, the activating drive. And the parasympathetic nervous system, which is opposing it, is very much about the calming response, the relaxation response. And these are always in some sort of balance and sometimes off balance. So we're thinking that there is some sort of dysfunction in this system. Interestingly, dysautonomia is very commonly associated with orthostatic intolerance. And what is orthostatic intolerance? Well, I think most of you will experience it every day of your life because it is the phenomenon of experiencing symptoms, a variety of symptoms, when standing upright. Okay, and it's essentially due to insufficient blood supply to the brain. When we are lying flat, there's less work to do for the cardiovascular system to perfuse all parts of the body because you're flat. As soon as you stand up, it has to fight against gravity. So what are the factors that control the blood supply? Well, I suppose it's the heart pumping, how often it pumps, the blood pressure in the system, which is very much determined by how tense or tight the blood vessels are. Okay? We know that in hypermobility spectrum disorders, the suspected issue is a laxity of a protein called collagen, which is present not only in our tendons and our ligaments, but in our skin, in our eyes, in all the junctions and sphincters of our body, and importantly, wrapped around blood vessels. And we all can understand when collagen is lax, causing joint instability and pain, etc. But the association with the cardiovascular system is sometimes a little bit less obvious. And is it lax collagen wrapping around blood vessels that makes them floppy and not responsive enough, not contracting enough to get blood supply to the brain? Or is it some other mechanism, other autonomic mechanism? And I think, I don't know the answer to that. I suspect it is that every aspect of the system has laxity because that's what's going on everywhere else. Symptoms of orthostatic intolerance are made worse by a variety of things, and one of the main ones is dehydration, but altitude and alcohol and heat. So these symptoms, which I'm going to outline in a moment, get worse in those areas. Now, it's important to recognize that orthostatic intolerance can be thought of as both acute OI and chronic OI. Now, everyone knows what acute orthostatic intolerance is. It's standing up, feeling dizzy, lightheaded, having visual symptoms, feeling faint, and sometimes actually fainting. Okay, it's obvious, it's acute, it's dramatic. You can see it in real time. What's less easy to understand or recognize is when those features are present, but they're present at a lower grade all of the time. Obviously aggravated by certain situations I mentioned before. And the cluster of symptoms associated with chronic orthostatic intolerance are listed there are, top of the list, brain fog, inattention, also problems with working memory, problems with planning and organization, functions of the frontal part of the brain, anxiety, sleep issues, migraines, headaches, tiredness, and heat sensitivity. And I see it quite simply that when the brain is not getting sufficiently perfused, it functions under par. It doesn't do all the things that it needs to do usually. And it's very often not picked up or considered, and I think it's a big problem. So what happens with the system when it experiences chronic orthostatic intolerance or acute orthostatic intolerance? Well, the first thing people do when they feel dizzy and lightheaded is they lie down flat. Obviously, it's less force against gravity. That can be a conscious thing. I need to lie down because I'm feeling dizzy and lightheaded, or it can be an unconscious thing, collapse and faint, and the body does it for you. Another way of perfusing the brain better, and this is both conscious and unconscious, is pumping of calf muscles. Okay? You can see the image here that I've included, that veins run through the calf muscles, and as they are pumped, it pushes the blood up the body like a shaft of fluid. You're literally shifting a column of blood up the body, and that often improves the symptoms. Now, I want you to keep that in your mind for a bit later on, because what we see in ADHD is a lot of hyperactivity and restlessness, people bouncing their legs and pacing and shifting position, not liking to sit still for long periods. And I suspect, if my theory is correct, that part of the reason they're doing that in some cases is a perfusion-related thing. Now, this is another area which is not discussed in the literature, and it's my own understanding of some of the symptoms of chronic and acute orthostatic intolerance, is that what does the body do when it's not perfusing the brain enough? It says we need to react in a way that will boost the blood supply up there. And what it does is it generates the stress response. That sympathetic nervous system goes into hyperdrive. And the aim is to increase the pulse and increase the blood pressure, because both of those things will increase perfusion to the brain. The problem is activating the stress response in the absence of a stress is an inefficient and unpleasant way of doing it, and it comes with a lot of symptoms. Sorry, I'm going to just take that back to the last slide. We've got to understand in stress and trauma that what's happening in the brain. One of the things that happens, as Chad talked about before, is that in the face of trauma, an acute trauma, you don't want to be over-analyzing and thinking about things. You want the blood supply that's present in the brain to be focused in on the survival centers and that core bit of the brain that will make you react quickly, not stop and think about things for too long. So one of the other things that happens in the presence of stress is that blood gets preferentially diverted away from the frontal thinking, planning parts of the brain to the more subcortical regions. So why is this all relevant? Because the symptoms of ADHD can be entirely explained by acute and chronic orthostatic intolerance. The key symptoms of ADHD are inattention, distractibility, there's working memory problems, there's impulsivity, hyperactivity, restlessness. We talked about the difficulty sitting still. There's anxiety, and there's mood instability. And you can see either through the issue of not enough blood supply getting there, or through the body's response generating the stress response and the need to move, you can see how there's a huge amount of overlap. And I suspect that some of what we're seeing in ADHD, which is ultimately a final common pathway, probably of lots of things, is explained in this way. So what other parallels are there? Well, they both follow trait-like courses that are consistent through childhood, adolescence. They both have a genetic basis, and they both cause real problems, significant impairment. And what's fascinating is that people I'm suspecting that people with hypermobility spectrum disorders and orthostatic intolerance may be responding to ADHD treatment not because of its effects on dopamine and noradrenaline, but because it's increasing blood pressure. It might be the side effect of the stimulants that's actually causing the improvement. And we say, great, their ADHD is improved. But it's possible that we've missed a link. So ADHD, I haven't got time to talk in detail about ADHD, but it's hugely impairing. And at each stage in life, with new demands and changing environments, different impairments become more prominent. And those are a few of them. And you'll probably notice some parallels with your experiences as well. So I decided that I was just going to invite one of my patients who has ADHD and suspected EDS. In fact, I've sort of made a provisional diagnosis because she's still on a waiting list to be seen by a specialist clinic. I know she has EDS and she also has ADHD. And I asked her to do this, and I'm going to play 3 very brief clips in the last minutes of my presentation. So let me just play this.
I'm Amy Davison and I'm 18 years old.
Can you give a 2-minute summary of your case?
Well, I have undiagnosed EDS and ADHD. Well, diagnosed ADHD. We're 10 months in for an 11-month wait for the hypermobility clinic where I'm going to get a diagnosis.
And what's it like living with EDS and how does it impact on your day-to-day life?
It's painful, it's isolating and tiring and stressful because you're always in pain and worrying about when the next thing is going to be popping out. It's aggravating all the time to be constantly having to worry about it and be in pain. And when they're really bad, it's so aggravating that it's like you could blow up and just scream.
How do you think ADHD complicates the picture?
Well, it makes it harder to sleep and rest my body. It's difficult to put it into words, so it was really hard for years to be able to describe to anyone what I was feeling or why I was feeling it, because I didn't even know. It's also that I can't remember to take my meds very well, although I've gotten better at that recently. And medication helps because when you're happier, it doesn't affect you so much because your mental state has a real impact on your physical health with hypermobility.
So we're going to tell you a little bit about Imogen briefly, but she's already introduced herself. She's doing her A-levels. She had to retake a year because of all these problems. She experiences anxiety and sleep problems, and she manages her pain, sleep difficulties, and anxiety with alcohol and cannabis, and that's obviously a dysfunctional way of doing it. She described mood instability, long-standing. She's had depression before, issues with anger and regulating her emotions. And she's had a diagnosis of ADHD since the age of 16, and she's tried most of the medications, but pretty much all of them she doesn't tolerate. And she's currently taking a non-stimulant medication, but it's a fine balance because it can reduce blood pressure a bit. So it's not a straightforward case of management in her case. So I recently diagnosed EDS, provisionally at least. She has a family history of hypermobility and lifelong history of joints popping in and out and lots of pain. And then all these systemic features that I've listed here. So you can see how you can relate to many of these. And she gives a strong history of acute and chronic orthostatic intolerance, and I've listed some of the symptoms there. I asked her to talk about her experience of orthostatic intolerance, and I'll play it for you now.
Well, I get head rushes all the time. whenever I stand up, I get floppy veins, which sounds gross. I ended up in the hospital because I had a really bad case of tonsillitis and I couldn't breathe, and I also couldn't drink, and they could barely get a needle into my arm to put painkillers in me to calm my throat down because they couldn't find a vein because my veins were so tiny. I get dehydrated very, very easily. I'm always jittery and I always feel weak and nauseous. And I always feel like something could set me off at any point. Like, my emotions are always right up at the surface.
What do compression stockings do for you?
They help a lot. They ground me, and I don't know whether that's psychosomatic or actually because they work, but they feel nice, yeah. They keep it's like someone's holding my ankles and holding your bones in place is actually really, really good and stops the pain for a while. So it helps with the pain that's constantly in my ankles.
What's the most comfortable thing for you in bed? To sleep?
Sleep on my...
So I'm going to move forward because I'm just aware of time. So things that have helped Imogen, so obviously the stuff that's going to be relevant to her joint issues, but also her mental health. She's been working with a Pilates specialist who works specifically with people with hypermobility syndrome and has found it hugely helpful. And she comes to see me and says that not only are my strengthening parts of my body, but the work we're doing is having a real positive impact on my emotional well-being as well. I've got to tell you, if there's one take-home message from here, it's that I have seen more improvement from one intervention than anything else, and that's compression stockings or flight socks. Again, we've talked about the idea of the calves pumping blood up the system. Wearing compression stockings during the day, not at night, literally just lifts the blood supply higher, and people report massive improvements in this sort of package of orthostatic intolerance. She has increased her hydration. She uses small bits of salt during the day to put in fluid into the blood vessels, and she regularly pumps her calves and has learnt to adapt the way she moves accordingly. The treatment of the ADHD has been effective, and we're thinking about pregabalin for her pain. Now, I've got 2 more videos, but I'm going to skip them because I have a couple more things I want to say. If there's some time at the end and you'd like to see some final reflections from her, we can do that. What are the particular challenges of having ADHD and EDS together? Well, first of all, diagnosis, separating what's what. It's an issue. I've spent the first part of the talk exploring that. The symptoms of one, without a doubt, compound the other in both directions. They both are associated with huge mental health burden. When you are more impulsive and you take more risks, you're more likely to get injuries. And ADHD is certainly associated with impulsivity and more risk-taking behavior. And ADHD also affects your ability to manage your life, to remember to take medications. Imogen said it herself, she forgets to take her meds, but also to attend appointments, to do the physiotherapy exercises that you need to do. It's a real problem. ADHD is associated with substance use, which can aggravate EDS for various reasons, and both conditions have loads of stigma and a huge lack of knowledge associated with them. There's not enough services, and the medications that we use in both areas are often tolerated poorly. So what needs to change? Well, I think the medical world, the wider world, needs to understand this is a very real problem, both conditions, that they're hugely impairing, and that there's no longer any rationale for dismissing this massively impairing and very real condition. There needs to be more research, there needs to be specialist services, and in both camps, the ADHD world and the HSD world need to be looking out for the problems that overlap. So there needs to be screening for ADHD and anxiety in HSD, and there needs to be screening for HSD when you're dealing with ADHD and anxiety. And I'm leaving you with this, another patient of mine. She didn't want to do a video, so she wrote her personal account of living with hypermobility and ADHD. And you can read it yourselves, but I'll just read out the last paragraph. She said, "I found it beneficial to learn about how my hypermobility and ADHD can be connected. For example, the link between my blood circulation and my ability to concentrate. Some small changes, such as wearing flight socks, drinking more water, and eating salty snacks, have significantly improved my concentration." And if I can get away with improving people's concentration without giving them medication, bring it on. Thank you very much indeed.
Fantastic, thank you. If everyone could move to a microphone if they have questions in the room, and I'm going to read some from here. If you press on the yellow button before speaking. So this one is for you, Helen. How can we tell if chronic pain is a faulty pain system or constant acute damage?
Try again. Oh, there we go, that's better. That is a typically difficult question to answer. I think if you have EDS and you've had it all your life and you're more prone to getting damage, you will get chronic pain and you will get a chronic pain wind-up. But just remember that when you've got a sensitized pain system, that pain is not about damage. That doesn't mean that you can't get injuries on top of that. And if you have an injury, you know your body. And if that injury means that this is different, this isn't my usual pain, I've done some damage here, of course you need to see someone and get some advice. But usually I'm afraid the answer is mostly it's a wound-up pain system. But of course you can get trauma and you can get damage on top. So you have to read between the lines, know what your body's like, and know when it's not right for you.
Thank you. There's one in the room here.
I was just wondering if you've run into, because obviously you're finding that people who have ADHD actually have ESD, and are you also running into people being misdiagnosed with personality disorders?
So, yeah, there's a lot of misdiagnosis in both our fields, actually. So in ADHD, very commonly, it's either been missed or it's been labelled as emotionally unstable personality disorder or bipolar disorder. So I'm very used to this concept of misdiagnosis. But it's very important also to recognise, based on the first talk by Chad, one of my main other interests is actually in trauma, psychological trauma. In fact, my whole of my psychiatric model, with a few exceptions, and ADHD's one of them to a degree, is entirely rooted in a trauma model. When you experience trauma, it either gets integrated, as Chad described, or it remains charged, alive, in the moment, and is regularly activated. And I think over a lifetime where you're struggling with pain and all the other things, all the other challenges of HSD, but also the same as ADHD, it's virtually impossible not to collect up a lifetime of trauma. And that does change things. It doesn't necessarily, I don't like the term personality disorder. I see things in a trauma model. And the reason why I do is because, as Chad mentioned, we now have super effective techniques of processing trauma. I'm also trained in EMDR and EFT, and I would thoroughly recommend that everyone who hasn't already get online and teach yourself how to do EFT on yourself, tapping on yourself. It is life-changing. It's changed my life, it's changed my understanding of my field, and it's allowed me to see things in a trauma model, which allows you just shift things, and therefore it's not as stuck as you're fundamentally flawed. But to say that these experiences don't change you is untrue. They do change you. You harbour lots of beliefs and emotions and resistance and avoidance. But the take-home message is it's entirely, it can be processed where that charge can be completely taken away. It takes a lot of work, though. And tapping on a daily basis, both in response to problems, but also in a proactive way to set yourself up with a positive outlook for the day. Hugely impactful. EFT, emotional freedom techniques, very good.
Thank you. Is there any advice for addressing adherence in ADHD?
Adherence?
Yeah.
It's funny. About 10 or 15 years ago, I saw adherence of medications as being like such a big problem. You know, when you see the data on how many people, generally not with ADHD or HSD, forget to take their medication, how much they forget to take their medication, I suddenly realized that adherence was a serious problem. And I actually designed a device which I tried to patent. I shed it in the end because it was just too ridiculously expensive to maintain it. But the device was, and the reason I'm saying this is I think there's a learning from it. The device was essentially a sheath into which you stick your toothbrush, and in the base of it there was a cavity where you could slide your pill sheets inside in a little cup on the bottom. And the idea was every time you went to brush your teeth, you would visually see your pill sheet there. You'd open it up with the cup and take the pill out and take it with water. So at least 2 occasions in the day, assuming you brush your teeth twice, you would be reminded of taking your meds. Now, I'm not suggesting that you try and create that device because it causes all sorts of problems, but putting pills near your toothbrush, putting reminders on your phone that set alarms off, and building it into your routine on a regular basis. And when you have multiple medications to take, asking the pharmacy to load it up into a Dosset box so that it's all organised for you. Because a number of people, particularly if you're rushing or you've got inattention or distractibility, you can't remember whether you've taken meds, and then you start getting the opposite problem, which is taking too much.
And in thinking of that question with physiotherapy and managing that, either of you, like managing to keep up with that routine, ADHD?
I think it's the importance of recognising that things like physio and rehab, they're not instant fixes. You need persistence. If you can keep doing it a little bit, but keep doing it and keep doing it and keep doing it, that's when you get the benefits. So it's a bit like blood pressure medication. You have to keep taking it to get the benefit, and you don't necessarily realise the benefit you're getting of taking a blood pressure medication. And I think some of those exercises and stretches that we do are similar. They're not going to work if someone overfaces you and gives you too much, and then you pay for it. That's a classic one, that someone gives you far too much to do, or tells you to get on an exercise bike when you know you can't do it. But getting a level that works for you and being able to do it really persistently, it just becomes part of the routine, because you get the payoff long term, not short term. And I think that's quite often, again, I think people do a couple of months and think, well, it still hasn't worked. A couple of months is nothing. You've had this all your life. You need to keep plugging away at it.
And I'll just add one thing to that. We say in ADHD, if it's not in your weekly ongoing schedule, if it's not on Monday afternoons I do this and on Tuesday mornings I do this, then it doesn't happen. So as far as possible, build in a routine that's fixed and structured and diaried and linked to alarms, and just reinforce those patterns. And if you don't have a physio appointment, then use the same time to do exercises at home.
Thank you. Back there. Yeah.
Hi, listening to you talk about ADHD has made me feel quite excited because my 15-year-old daughter is having a really difficult time at the moment. She is struggling at school, which is causing anxiety, and she's becoming more and more reclusive. She has EDS, she has POTS. I've tried to get her to see a counsellor, but she just will not go. She refuses to talk about it. The school won't help. Our GPs, we don't have one as such. It's just a continuing locum. How do I I believe from what you've said that she probably has ADHD and this is what's causing all of the issues. How do I get that diagnosed when I haven't got a GP that understands?
Change GP.
I live in a very small place.
Ask to be seen by a different GP in the practice.
So when I see the GP, who do I ask
to
sure.
see? So I think that it's really important when you have a GP practice to try to find the GP that's going to be most understanding. And in my field, I advise people to ask whether any of the 5 GPs in the practice have an interest in mental health. That's the first angle. So often they're a bit more understanding and not brushing things away. So it might be worth doing that. And I think try to build that relationship and with one person. And if you can't find it, then I think you have to shift GPs or put a complaint in to the GP surgery. In terms of what you're asking for, you're asking to be referred, for your child to be referred to Child and Adolescent Mental Health Services, CAMS. ADHD is bread and butter for children and adolescent mental health services. It's probably amongst the highest percentage in terms of their workload, less so with adult mental health, but I think you need to just push for a referral for an assessment, and then the ball should roll from there.
Thank you.
But get the compression stockings on her first.
She has them already.
Top right.
Thank you for today. Before I was diagnosed with Ehlers-Danlos hypermobile syndrome, I went to Edinburgh for 3 weeks on the chronic pain course clinic, and they tried to take you off all the medication. Now I've found I've got HEDS, and the antidepressants might not work, and the pain relief might not work. Is there a reason behind it for the HEDS sufferers why it might not be as effective?
Well, certainly in terms of the painkillers, you've already gathered it's not just EDS, it's chronic pain, full
Exactly,
stop.
yeah.
And the reason the painkillers don't work much is because they don't do anything about perception. For years and years and years, we've just focused on how pain nerves fire and looking at all the chemicals and all the genes, and we've never actually really started to look at brain perception. That's relatively new. Even now, Big Pharma are looking at lots of new molecules. They'll dare say there'll be more drugs. Big Pharma are desperate to have a really nice, expensive drug for chronic pain because it's so common. But I can't help but think it might help a bit, but it's still not going to be a cure because you're still not taking any notice of what the brain and perception does and that whole complexity of pain. There's not one molecule that controls the whole of pain. And even if there is, and you switch pain off completely, as you've already seen, you can't do that either. So there's a good reason why painkillers and medications used in chronic pain, they may be helpful, but they just don't make it go. So if you go into it saying, okay, I'm looking to see how much benefit I can get, if that benefit is enough that I'm getting a bit more control, which gives me a bit more quality of life, allows me to do more, that's a reasonable use of that medication. If it's doing nothing, or you're getting pills for the side effect of the pills for the side effect of the pills, you're on the wrong way. And actually that needs to be reviewed as what can I get rid of. And for some people, I have a lot of people that manage on very little. The odd paracetamol, the odd cocodamol, maybe a small dose of gabapentin pregabalin, but again, often at the lower doses. Other people do need more. So we are individuals. It is a balancing act, but you have to get that balance.
So it's not HEDS, it's chronic pain?
It's chronic pain.
Thank you very much. Thank you. Top left. Yeah.
I don't know really how to word it. I'm a bit confused about not feeling pain, but for example, my jaw dislocated quite often in the last couple of months, so I'm in an A&E, and they'd ask me what's the pain scale, and I have a vague idea I have pain, but it's psychological. I'm wondering, is not feeling pain sometimes psychological disassociation, or are the pain receptors not actually, or they're damaged or something? And is it bad if I'm not feeling pain? Am I causing damage underneath the pain?
No, not necessarily. Again, bodies and brains adapt. So you've probably found you're adapting. Now, it may also be that the jaw's capsule has stretched. You've got more give. So sometimes if you've got more give, things can move more, and it's got used to that. Then no, it won't be as painful as someone with a very tight, narrow jaw. The slightest stretch, you're going to know it. It tends to be the stretch that's the problem. So if it's already lax and more stretchy, that may be why you just don't get as much pain.
Is there a long-term, problems going to happen because of, the continuous dislocations, or is it because there's no pain, it's fine, it's just going to go in and out and put it back in,
Yeah, I mean, again,
I don't know if this
it's the
is
sort
a
of
stupid
conversation.
question.
Yeah, it's the sort of conversation you have to have with these. Usually, it's maxillofacial people that treat this sort of thing. So if you're not under a max fax, that's usually who it needs to be. Occasionally, if it's not max fax, it's special care dental teams, but usually it's maxillofacial. They would need to know structurally what the problem is. For some people, there are structural issues, and they do want to have a closer look. For other people, they say, actually, you don't have a structural issue, and actually it's just lax, so no, you don't need to worry.
Okay.
But often you need that little bit of information to know, and that's usually maxillofacial teams that deal with that.
Okay, thank you.
I'm going to do 2 quick questions on the app, and we're just against time, so as quick as we can. It's been talked about today about a link with EDS and autism. Have you also seen any links with gender dysphoria?
Well, I can say from my experience, I don't think I've seen anything in the literature, just from my experience of patients coming through our programme. Now, bear in mind, we're a tertiary centre, so we're the only UK centre that do a specific EDS rehabilitation programme, so I do tend to get the bad end of the spectrum of people. Yes, I see far more than would be expected in the general population. So absolutely. Is it out in a paper yet? No. Is it something I want to look at? Absolutely. So yes, I do. Do I see it more compared in the general pain population as well? Because I also see people with chronic pain that don't have EDS. I think I probably do see more there as well. But again, I don't think the literature is very good on this yet. So I think it's a watch this space one.
Thank you. And something that I know echoes around our community, there's often a misdiagnosis of Munchausen's. How does one avoid this hypochondriac diagnosis when some symptoms are often very unusual and troubling for us?
That's a complex one.
$1 million question.
I think, having reflected on the way Western medicine for a long time, I think we have a problem here, which is that evidence-based medicine is absolutely important. Obviously, every doctor will say, it's really important for things to be backed up with studies. The problem exists now that when a doctor doesn't know about something, they don't feel that there is enough evidence on it. They don't say, that sounds interesting, tell me more. They say, there's no evidence to support it, it's rubbish. This is a fundamental flaw in evidence-based medicine approach. You have to be flexible and open. The answer, and it happens a lot. What also happens when people are ignorant to something, and they just haven't been taught it, and they haven't put the pieces together yet. I hadn't been taught it before, and I didn't put the pieces together. And when I did, through learning, my perspective changed. The problem is, often when doctors are ignorant to something, rather than say, I don't know, and show ignorance, they say, it's a load of rubbish. So the outcome of all of this is to say, whether it's resources online, provide short but evidence-based summary of hypermobility spectrum, EDS, give it to the doctor. Don't then have the conversation straight away, ask them to read it. And then when they've digested it and reflected on it, then open up the discussion to avoid that ignorance block.
I also once saw, and I'm trying to remember for the life of me where, a useful session, and I can't remember if it's an EDS one or a chronic pain one, on basically training you to get the most out of your doctor. And it was a really good session. And it was simple things. One, your doctor's probably terrified of you. The moment you walk in the room, you will probably know more about the condition than they do. You're probably one of the more complex patients they have to deal with. They've got 10-minute slots for one thing, and you're probably going to come in with a shopping list. So your doctor's frightened of you. So number one, you need to learn how to get the most out of your doctor. So as my colleague has just mentioned, ideally you really should have a GP that knows you rather than a series of locums. When you go to see your GP, try to go with one or two really important things. Don't go with a huge list that they're just going to go, oh, they're nuts, I can't cope with this. Go with one or two really key problems. You might then have to have several visits over time, but that way you will probably get it solved one at a time. If you need referrals or you think you need referrals, don't come in demanding referrals. Guide them towards it so they think they've actually come up with the answer. And it can be as simple as that. Doctor, I've heard about this thing called autonomic instability, and I've got this and this and this. Do you think it might be? And then when you see them starting the penny drop, or maybe, well, I've heard that there might be this specialist somewhere that could help. Do you think it would be useful to see? So take it one bit at a time. Don't overload them. Take one or two bits. Take it over time. Don't frighten them. You want them on board.
Thank you. Lady on the right.
Hi, thank you. Firstly, I just want to say it's been really refreshing to hear you talking about EFT. I had that 15 plus years ago with a therapist who was an alternative practitioner, and it was what got me well way before I knew I had EDS, but it got me well with lots of symptoms I was experiencing. And the other thing that really worked well for me was nutrition. And I'm really interested, watching this, I have an EDS diagnosis, and I'm under consultants for POTS as well. So the OI really is a big pain for me, but I find that I manage my life the best when I'm active and when I'm eating well, and that sometimes is really hard. Some days I can't be bothered and I don't particularly want the effort of having to do it, but I know there's a real strong correlation between what I eat and how I feel both physically and mentally. So I'm just really interested in, is it an interest of yours? And if it isn't, are you working with people looking at nutrition? Because medication's got a place, but if we're popping pills as a quick fix, but then I'm eating sugar or meat or things that are wrong for my body, then we're never going to get the results we're looking for.
Okay. So the answer to your question is yes. I've got a strong interest in nutrition. I actually trained as a nutritionist because I wanted to be able to have proper conversations about it. Because it's actually very hard to know what's true in nutrition because you get so much conflicting advice. So it is a centerpiece of the work that I do. And in my team, we have 2 nutritionists and a dietitian. And I'd say I offer nutritional evaluation to, this is in private practice, but to every one of my patients after I've assessed and if I've made a diagnosis. Not all of them take it up. And where they don't, I provide some guidance. And what I've learned over time is avoid anything radical. Radical changes, big diets. 1, you won't sustain it, and 2, it's not the right way to do it. Small, incremental, positive changes. So, you know, if you drink lots of Diet Coke, just say, okay, I'm going to stop drinking Diet Coke and replace it with fizzy water. I'm going to, you know, just small things that are not seen as a hassle or a restriction, but are seen about eating tastier and better foods. And the last thing to say on this is gut balance of bacteria is showing itself to be very, very important across the board, and particularly in mental health and with anxiety. And I think particularly with EDS, when the peristalsis through the gut is not coordinated because the collagen that's around is not contracting in the right way, you get stasis, which means you don't get a flow through. And when everything sits still, they fester and they get bacterial overgrowth and yeast overgrowth. So doing a microbiome analysis, so a stool sample and finding out what's going on in your gut, is a great way, and it's not done on the NHS, and it can be expensive, but it's a great way of knowing what's going on. And then, if you're going to use probiotics, you can have some targeted approach to it. But I strongly recommend people bringing fermented foods into their life, whether it's kefir or sauerkraut or kombucha or a whole variety. They taste great and they're superbly effective at repopulating the gut healthily. And yes, it does make a big difference.
Thank you. Thanks to everyone. I'm sorry that we have run out of time. We didn't get everyone's questions in the room, but everyone is hanging around today to answer questions. One question we did have come through the app is, what are the society doing to improve awareness of mental health and EDS without perpetuating the stereotype that people living with chronic illnesses, including EDS, are attention-seeking, hypochondriacs, and all of these things? The answer is, this is what we're doing. We're making this a safe conversation, a safe community for you all to live in and not be scared to talk about this connection. And we are incredibly grateful to people like this who are here without any charge, with their own time, dedicating themselves to our community to make things better. So thank you. Thank you.